Hello doctors, I hope you're all doing great. Welcome to Easy Medicine. As we all know that it is important to do UHS past papers for class tests, send-ups or final exams. So in this video we will discuss Medicine 1 past papers for final year MBBS. Before starting, it is better to know how important a topic is and how much weight does it carry in the final exam. So here I have provided you with distribution of marks for Medicine paper 1. In this video, we will discuss cardiovascular system, and as you can see, you will have 2 questions from this topic. This is the first part of 2 videos on past papers of cardiovascular system. You can find the link to the second part in description below. I would also like to mention here that you will see a blue box in right corner of your screen with every answer. This will provide you with page number of Davidson's Book of Medicine from where the answer is taken. I have done this to make sure that these answers are accurate by taking them from a good UHS recommended source. For the purposes of this video, reference page numbers are taken from 22nd edition of Davidson's Book of Medicine. For your ease, I have grouped those questions which were asked on the same topic, so you might see 2 or even 3 questions grouped together during the video. Let's begin. There were 3 questions asked from this topic. 2 of them are mentioned here, one you will see in just a second. Please stop the video here, read these questions, try to answer, and then we'll discuss them together. Very good. So the diagnosis is heart failure, and some points to diagnose this condition are dyspnea, orthopnea, and fluid overload indicated by pedal edema, raised JVP, and basal crackles or crepitations involving both lungs. And you can see same points in third scenario as well. Students might get confused that JVP is not raised in this scenario while it was raised in the previous scenario. This is because JVP is raised in right heart failure, and as we know, long-standing left heart failure eventually leads to right heart failure. And the patient in last scenario had long-standing history, therefore he developed right heart failure, which has resulted in pedal edema and raised JVP. While the patient in this scenario has acute history, therefore he has not developed right heart failure yet, and his JVP is therefore not raised. Another point to be mentioned here is that whenever a clear cause of heart failure is present in the scenario, it is better to write that cause with the diagnosis. For example, this patient has raised blood pressure, so it is better to write hypertensive heart failure as the diagnosis for this patient. However, you can also write simple heart failure as a diagnosis as well. Let's see the answer now. And here you can see the answer is heart failure. All previous 3 questions asked about investigations for this condition. One of the questions also asked to justify these investigations. So here are the investigations and their justification. First investigation is checking serum urea, creatinine and electrolytes, and this is done to detect any complication of heart failure such as renal failure, which can occur in long-standing heart failure. The next investigation is echocardiography, and this is done to determine the cause of heart failure and to detect any valvular disease. Next is chest X-ray, and this is done to detect early signs of heart failure and confirm pulmonary edema. All 3 questions asked about management, and as I have always discussed that every management begins with history and physical examination followed by investigations, and investigations are same as given before. And the next is treatment, and treatment of heart failure involves 2 things. First is management of acute pulmonary edema, and second is management of heart failure itself. So treatment of pulmonary edema is by propping up the patient, giving oxygen by CPAP, administering nitrates until systolic blood pressure falls less than 110, and administering loop diuretics. However, if all these measures fail, then use inotropic agents. Next is management of heart failure, which begins with general measures, such as educating the patient about the disease, diet control, regular exercise, smoking cessation, and treatment of underlying cause of heart failure, example severe hypertension, as it was seen in one of the scenarios where hypertension was the cause of heart failure. And next is drug therapy, and one of the questions asked about 5 groups of drugs which can be used in this condition. So these are diuretics, example loop diuretics or spironolactone, angiotensin converting enzyme inhibitors, example lisinopril, angiotensin receptor inhibitors, example losartan, vasodilators, for example nitrates or hydralazine, beta blockers, example bisoprolol, and other drugs, example ivabradine, digoxin and amiodarone can be used in selected patients only. Other treatment modalities for heart failure include coronary revascularization, implantable cardiac defibrillators, heart transplantation, and ventricular assist devices. And as discussed, the reference page numbers from Davidson from where these answers are taken. Let's read the next questions. There were 3 questions from this topic as well. 2 of them are mentioned here, one you will see in just a second. Please stop the video here, read these questions and try to diagnose before we discuss them together. Excellent, so the diagnosis is stable angina. And some important points which can lead you to this diagnosis are chest pain which occurs only with exertion or stress and relieved by rest. And here you can see the same points in third scenario as well. Let's see the answer. And here you can see the diagnosis is stable angina. One of the questions asked about causes of pain behind the breastbone. So the differential diagnosis or causes of chest pain are angina, pericarditis, aortic dissection, esophagitis, pneumothorax, and costochondritis. The important thing here is to differentiate these causes of chest pain based on their symptoms. So I will try to mention some important points for each of these which can help you differentiate between these causes. First is angina. And as we have discussed that chest pain of angina usually presents on exertion and relieved with rest. Next is pericarditis, and pain of pericarditis is increased with inspiration and decreased with leaning forward. Next is aortic dissection, and chest pain of aortic dissection is sharp and radiates to the back, and it is associated with unequal blood pressure between both arms. Next is esophagitis, and chest pain of esophagitis is related with eating. And chest pain of pneumothorax will be associated with examination findings of unilateral decreased breath sounds and unilateral hyperresonant percussion note. Next is costochondritis, and chest pain of costochondritis is associated with movement of the body and localized tenderness. All previous 3 questions asked about investigations which can help you diagnose this condition. So these are resting ECG, which is usually normal in patients of stable angina, and stress tests, which are actually diagnostic in case of stable angina. And these stress tests include exercise ECG, which is also called stress ECG, and myocardial perfusion scanning and stress echocardiography. Next is treatment of this condition, which begins with lifestyle advices, since one of the questions asked about advices which should be given to a patient with stable angina. These lifestyle advices include cessation of smoking, aiming for ideal body weight, and exercising only up to the point where chest pain begins, avoiding severe exertion, and taking sublingual nitrate before undertaking any such severe exertion. Next is drug therapy, and it involves 2 types of drugs. First are antiplatelet drugs, and these are actually for secondary prevention of myocardial infarction. And these include low-dose aspirin, that is 75 mg, or clopidogrel. Remember the dose of aspirin as it might be important for your MCQs or OSP. And the next type of drugs are anti-anginal drugs, and these are for controlling the symptoms. And they include 5 different types of drugs, which are nitrates, example glyceryl trinitrate and isosorbide dinitrate, beta blockers, example bisoprolol, calcium channel antagonists, example verapamil, potassium channel activators, example nicorandil, and IF or funny current channel antagonists, example ivabradine. One of the questions asked about invasive treatment modalities which can be used if the drug therapy fails. So these invasive treatments include percutaneous coronary intervention, which involves balloon angioplasty or stent placement. Remember that stent placement is preferred over balloon angioplasty. And the second invasive treatment is coronary artery bypass grafting. And remember that for bypass, grafts are taken from long saphenous vein or internal memory artery or radial artery. And among these, arterial grafts are preferred over grafts from the veins. And here is the blue box with reference page numbers from Davidson from where these answers are taken. Let's see the next question. Please stop the video here, read the question and try to answer before we discuss it together. Since the question does not ask about diagnosis, so let's see the answers. The first part in the question asked about various pharmacological steps for treating hypertension according to UK guidelines. So steps for treating hypertension are as follows. First, check age of the patient. If it is less than 55, then first step involves administration of angiotensin converting enzyme inhibitors or angiotensin receptor blockers. If the patient's blood pressure is still not controlled, then step 2 involves ACE inhibitors or ARBs with calcium channel blockers. If it is still not controlled, then step 3 includes administration of ACE inhibitors or ARBs with calcium channel blockers and thiazide diuretics. If the patient's blood pressure is still not in the reference range, then step 4 involves administration of ACE inhibitors or ARBs plus calcium channel blockers plus high dose thiazide diuretics or low dose spironolactone or alpha or beta blockers. And this type of hypertension is called resistant hypertension. The next part of the question asked about what will be the treatment difference if age of the patient is more than 55. So if the patient's age is above 55, then only difference will be in step 1, which will involve calcium channel blockers instead of ACE inhibitors or ARBs. The last part of the question asked about the tests which are required while the patient is being treated, and these involve blood urea, electrolytes and creatinine, urine analysis for protein and glucose, and ECG. These tests are basically done to see if the patient has developed any complication of hypertension, as we know that long-standing hypertension affects kidney and heart apart from other organs, and also to check for any side effects of the drugs being given. And here is the blue box with reference page number of Davidson from where this answer is taken. Let's read the next question. Please stop the video here, read the question and try to answer, then we'll discuss it together. Very good. So the diagnosis is aortic regurgitation, and some points to lead you to this diagnosis are high volume pulse, absent A2 component of second heart sound, early diastolic blowing murmur in left, third and fourth intercostal space which increases when patient bends forward. Let's see the answer. As you can see, the answer is aortic regurgitation. The next part of the question asked about signs which you will see on examination of pulses, and they are large volume or collapsing pulse, bounding peripheral pulses, capillary pulsations in nail beds, femoral brute, which is also called as pistol short femoral pulses, and lastly head nodding with pulse. The last part of the question asked about causes of aortic regurgitation, and they include bicuspid valve, rheumatic disease, infective endocarditis, trauma, and aortic dilatation such as in Marfan syndrome, syphilis, or aortic dissection. And here is the blue box with reference page numbers from Davidson from where these answers are taken. Let's read the next question. Please stop the video here, read this question and try to answer, and then we'll discuss it together. Good. So the diagnosis is atrial fibrillation, and some points to lead you to this diagnosis are irregularly irregular pulse, irregular QRS complexes and no P waves on ECG. Remember that whenever a scenario says pulse is irregularly irregular, think about atrial fibrillation. Let's see the answer. Here, as you can see, the answer is atrial fibrillation. The second part of the question asked about causes of atrial fibrillation, and they include coronary artery disease, valvular heart disease, hypertension, hyperthyroidism, and alcohol. The last part of the question asked about how will you manage this condition, and as I have always discussed, management begins with history and physical examination, followed by investigations, and investigation in atrial fibrillation include ECG, echocardiogram, and thyroid function tests. The last part of the management is treatment, and treatment of atrial fibrillation includes rate control with beta blockers, calcium channel blockers, and digoxin, rhythm control with flecainide and amiodarone, anticoagulation with warfarin. And if all these treatments fail to control atrial fibrillation, then resistant cases are treated with catheter ablation. One important point to mention here is that in resistant cases, site of catheter ablation is insertion of pulmonary veins in left atrium. And here is the blue box with reference page numbers from Davidson. Let's see the next question. Please stop the video here, read these questions and try to answer before we discuss them together. Very good. So the diagnosis is ST elevation myocardial infarction. And some important points to diagnose this condition are central chest pain with characteristic distribution such as radiation to the left arm or lower jaw, and associated sweating, and ECG showing ST elevation in various leads. Students are usually confused about how ST elevation in various ECG leads can tell about which wall of the heart is involved and which coronary artery is involved. So let me help you with that. As we know, anterior wall of the heart is supplied by left coronary artery, and posterior and inferior wall of the heart are usually supplied by right coronary artery. And leads 2, 3 and AVF are inferior leads, and ST elevation in these leads indicate that inferior wall of the heart is involved, as seen in the first scenario. And as we have discussed that inferior wall of the heart is supplied by right coronary artery, so whenever you see ST elevation in leads 2, 3 and AVF, this means that right coronary artery is involved and inferior wall of the heart has undergone infarction. In second scenario, ST elevation is seen in leads V1 to V6. These leads are anterior chest leads, and ST elevation in these leads mean that anterior wall of the heart has undergone infarction. And as I have just discussed, that anterior wall of the heart is supplied by left coronary artery. So whenever you see ST elevation in leads V1 to V6, it means left coronary artery is involved and anterior wall of the heart has undergone infarction. I hope it is clear now. Let's see the answer. Here, see, the answer is ST elevation myocardial infarction. One of the questions in first scenario asked which coronary artery is involved if ST elevation is present in leads 2, 3 and AVF. And as we have just discussed, it will be right coronary artery. Next part of the question asked about types of acute coronary syndrome, and they include non-ST elevation myocardial infarction, unstable angina, and ST elevation myocardial infarction. A question in second scenario asked about risk factors for myocardial infarction, and they include old age, male gender, family history, hypertension, diabetes mellitus, and smoking. Since the question asked about which risk factors are present in the patient described in the scenario, so let's discuss the risk factors present in the scenario. These include old age, smoking history, hypertension, and family history of sudden death. The next part of the question asked about management in emergency room of a patient with myocardial infarction, and that involves providing analgesia with morphine sulfate and antiemetics such as metoclopramide, antiplatelets example aspirin with clopidogrel, anticoagulants example low molecular weight heparin or fondaparinux, antianginal drugs example beta blockers or calcium channel blockers example verapamil. And lastly, reperfusion therapy, which can be provided with percutaneous coronary intervention or thrombolysis. However, percutaneous coronary intervention involving stent placement is preferred and is a treatment of choice if provided within 12 hours of onset of symptoms. Remember that greatest reduction in mortality is achieved when percutaneous coronary intervention is provided within 2 hours of onset of symptoms instead of 12 hours. But it can be provided within 12 hours of onset of symptoms, however reduction in mortality is less compared to when it is provided within 2 hours. If this is not available, then reperfusion can be achieved by thrombolysis by using drugs such as tissue plasminogen activator (LTPlase). And here is the blue box with reference page numbers from where these answers are taken. Let's read the next question. Please stop the video here, read the question and try to answer before we discuss it together. Good, the diagnosis is prinzmetal or variant angina. And some points which can lead you to this diagnosis are central chest pain which comes at rest and associated ST elevation in ECG with normal cardiac enzymes. And as we have discussed that ST elevation is present in myocardial infarction, so students might get confused. Remember that ST elevation in myocardial infarction is always associated with increased cardiac enzymes. However, cardiac enzymes are normal in this type of angina. There is also improvement of chest pain with sublingual nitrate in this type of angina, which does not occur if it is myocardial infarction. Let's see the answer. As you can see, the answer is prinzmetal angina or variant angina. The next part of the question asks about investigations to diagnose this condition, and they include cardiac enzymes, ECG, and coronary arteriography with or without a provocative agent, and this investigation is diagnostic for variant angina. The last part of the question asked about treatment of this condition, and it involves avoiding aggravating factors such as tobacco, beta blockers, and emotional stress. Acute attacks are treated with sublingual nitroglycerin, and maintenance therapy is provided with calcium channel antagonists or oral isosorbide dinitrate. And as discussed, here is the blue box with reference page number from the Vision from where these answers are taken. Let's read the next question. Please stop the video here, read this question and try to answer, and then we'll discuss it together. Since the question does not ask about diagnosis, but knowing this condition might help you in your exams. The condition described in this scenario is constrictive pericarditis, and some points to diagnose this condition are progressive dyspnea, ankle edema, hepatomegaly with ascites, and pericardial constriction on echo. You might also see pericardial calcifications on chest X-ray. Let's see the answer. Since the question asked about the sign found on JVP in a patient with constrictive pericarditis, that sign is Kussmaul's sign. The next part of the question asked about causes of this condition, and they include viral pericarditis, rheumatoid arthritis, radiation, tuberculous pericarditis, and cardiothoracic surgery. And among these, the top 3 causes of this condition are viral pericarditis, radiation, and cardiothoracic surgery. And the last part of the question asked about treatment. And the mainstay of treatment of this condition is surgical resection of stiff pericardium. Analgesia is provided for pain and inflammation, and fluid overload such as ankle edema or ascites, as seen in the scenario, is treated with diuretics. And here is the blue box with reference page numbers from Davidson from where these answers are taken. And this finishes first part of the video on past papers of cardiovascular system. You can find rest of questions and some MCQs in the second part of the video. If you have any query, feel free to ask in the comments below. I'll be happy to answer. If you like this video, give a thumbs up and share it with your friends so that they can benefit too with these past papers. And I'll talk to you in the next video.